Today we'll be talking on an interesting topic, regional anesthesia for head, face, neck surgeries, which is, not done very often. Most of them will be LOR blocks, but then to give you a fair idea about which block to use for what surgeries. So I have given example of the cases which I have conducted, and accordingly where you can use these blocks for, along with general anesthesia, also use sono also for these blocks. Okay, so I'll be showing mostly LOR guided blocks. Okay, this is a big thank you to all my surgeons and patients for allowing me no disclosures, and this is a photo video consent form which we take from all the patients. Now these cases like thyroid, this patient had severe COPD, and she was shelved, and huge thyroid pushing the midline, and the sternocleidomastoid also, the anatomy was distorted on the left side. And this patient was not being little hoarseness of voice, difficulty in swallowing, though non-malignant, because of her severe COPD, she was not taken for surgery, and they couldn't afford to go to bigger centers. This was radical neck dissection, which we generally do under general anesthesia. And this is parotid surgery, parotid on cancer, actually malignant parotid, and total parotidectomy, mostly done under GA. Now, coming to cancer tongue lesions, this is they do a wide excision and then bilateral radical neck dissections. These are generally ideal anesthesia technique is general anesthesia with endotracheal intubation, with or without muscle. But not everybody is affording, or nor we can shunt patients to higher centers. So we need to know blocks of head, face, necks. What are they? Mainly for neck is the cervical plexus block, that is the deep cervical plexus blocks, and the superficial cervical plexus blocks. For the face, the innervation comes from trigeminal nerve and its branches, and then the scalp blocks for scalp surgeons. Okay. Now coming to the cervical plexus, we'll go from the cervical plexus upwards to the scalp. The cervical plexus is formed by a conglomeration of cervical nerves from the anterior rami of your spinal nerves, that is C1, 2, 3, and 4, giving both the muscular and the superficial sensory branches, that is the anterior rami branches of C1 to C4, and anterior ramus of your C5 cervical plexus. Okay, so the superficial branches, they come out behind your lateral border of the sternocleidomastoid muscle. Let's see, lateral border of the sternocleidomastoid muscle at its midpoint. Give a good block, So you have to be you can see the external jugular vein unless the patient has a lot of edema and fat and short neck, you may not see. So then you need a sono-guided approach for the block. And where is the innervation? From the lateral pinna. Okay, behind it, see, from the lateral pinna, behind it, okay, and the mastoid along the lower jaw up to the clavicle in front, see, midline, and then the clavicle till the midline and the upper shoulder also, that is the anterolateral part of the neck. Okay, that is the innervation. See, pinna, the jaw, the midline, okay, and the clavicle up to the upper part of the shoulder. This is the innervation of the cervical plexus. So therefore, what are the indications of anything, any surgery along in this area? Okay, so that is your lymph node biopsy, your thyroglossal cyst, your branchial cyst, your vascular excess, IGV cannulation, the mastoid surgeries, radical neck dissections, even parotid some extent, and earlobe repair, okay, mastoid surgeries, anything will need a cervical plexus block. Okay, so this is the transfer section image. So what happens is, see, at the neck at C6 level. Okay, so this is your sternocleidomastoid muscle. Okay, and at the midpoint, the plexus emerges out. Okay, the sternocleidomastoid has an investing fascia of the neck. Okay, see the investing fascia of the neck. Outside the investing fascia, at the lateral border, okay, of the uh, sternocleidomastoid at its midpoint is your superficial cervical plexus. So outside the fascia, once you pierce the investing fascia, you enter, that is your intermediate. And for the deep block, where you have to go is, you have to pierce this deep cervical fascia and at the transverse process of the C6 vertebrae. Okay, so that is very deep. And intermediate and superficial cervical plexus is very superficial. Okay, why I'm telling you that, I'll come to that later. Now coming to the superficial cervical plexus. Okay, so for all practical purposes, the branches what you're blocking at the deep and the superficial cervical plexus remains the same, because you're blocking the terminal branches. These terminal branches emerge at the midpoint. Again, I'll repeat, of the sternocleidomastoid. What you do is, and the branches are in the mnemonic, that is GLAST, GLAST. They are the greater auricular, that's the greater auricular, okay, going upwards. Huh? Then you have your lesser occipital, that is the posterior part of your scalp towards the behind your pinnae. Greater auricular is the ear lobule and the anterior to the pinnae. Okay. Then you have the transverse cervical, which will supply the anterior part of this neck, that is mainly for your thyroid. Okay, then your supraclavicular nerves, they have three branches. Okay, so that is the medial, the anterior, medial, and the lateral branches along the clavicle, the entire length, very important for your supraclavicular lymph nodes, your humerus, your clavicular fractures. Okay, so that is your, and you have a accessory nerve. Okay, an accessory nerve, so that is the mnemonic. So what is the anatomical landmark? As I said, the sternocleidomastoid, from the mastoid to your clavicular head, you follow that. It is the midpoint. You can see the external jugular vein just above that. No, you have to push the external jugular with your 1 to 2 ml of LA. So then you can then give a fan shape, in fan shape directions, targeting, remembering the branches of the, where you want to and which type of surgery. Suppose you're giving thyroid, you will infiltrate more along the transverse cervical. If you have a lymph node or jugular or your humerus or clavicular, you will want to block all the supraclavicular branches. And towards the neck and for scalp block and the greater auricular and lesser occipital, it will be on the upward direction. Okay, so a fan shaped direction will give you complete block. This is the injection. How much volume you need is around 5 to 10 ml. Okay, of LA. So if you're doing a sole surgery, so using this block as a sole agent, anesthesia agent, you will give higher concentration, that is 0.5% bupivacaine or 0.75% ropivacaine. Okay. So this is how See that that's how I'm holding the, you can see the external jugular.